A very warm welcome to this biomedical webinar titled Important Functionalities for Effective Ventilation at Home. Thank you very much for joining us. I am pleased to inform you that the full live webinar is eligible for 1 contact hour of CRCE accreditation with the American Association of Respiratory Care, and please expect to receive an email from Vayer with a link to a post-webinar survey. We are honored to have Professor Cesare Gregoretti join us today as our speaker for the webinar. Following the presentation, we will have the opportunity for a short Q&A. If you have any questions throughout the webinar, please feel free to write them in the Q&A box, and we'll share these at the end for a discussion. So without further ado, I would like to hand over to Professor Gregoretti. Thank you very much.
Thank you very much, Chloe. Good morning, everybody. Gentlemen and women, ladies and gentlemen. So in the next 60 minutes, unfortunately, I will try to give you some information on important functionalities for effective ventilation at home. This is my faculty disclosure. So about 10 years ago, we wrote this paper on choosing a ventilator for home mechanical ventilation. And we enlisted some important elements for a positive pressure ventilator. Anyway, because we have just 60 minutes, we will try to focus on gas source, performance, mode and battery, type of circuits, valves and CO2 rebreathing, volume measurement and decompensation, user interface, alarm and portability. And
Professor Gregoretti, may you please share your screen for us?
Sorry, Chloe, you don't see the slides?
Not yet.
Strange. Wait, sorry for that.
You have to click on the green arrow.
Okay, I already did it. Now you see the slides?
Yes.
Yes, we do. You can enter the presenter mode. Thank you.
Okay, can I go on?
Yes, please. Thank you so much.
Sorry. So, according to the gas source, we can divide the ventilator in 3 kinds of machine. The first one, ICU high pressure driven ventilator, the ventilator that usually we find in a critical care area. Then we have a turbine or piston driven ventilator, and this family of ventilator can divide in other 2 families. The ventilator, they are fitted with oxygen provided at low pressure, and this is the case of a home care ventilator. There is no blender. Then we have also a turbine or piston-driven ventilator in which O2 oxygen is provided at high pressure, and this is called a blender. They look very, very similar, and you can see the family on TV, for example, on the right side of the picture, but they can be driven by oxygen at a low pressure or oxygen at a high pressure. So, for the standpoint of the blower, turbine ventilator can be further divided in dynamic blower system with change speed to reach the preset ventilatory output, and constant revolution blower systems, rotating at a constant speed and driven by proportional valve. Although in the past, constant revolution blower system had a clear responsiveness advantage over dynamic blower systems, recent developments show the dynamic blower with a small blower wheel diameter and a very high revolution rate per minute are also extremely responsive to patient demand. So, in order to evaluate the performance of ventilator, we have to talk about phase variable. The phase variable is a variable that is measured and used by the ventilator to initiate some phase of the breath cycle. The primary variable the ventilator adjusts to achieve inspiration is called the control variable, namely volume control or pressure control. Then we have the trigger variable that cause a breath to begin. There can be a time trigger, for example, when you set a given respiratory rate of the ventilator, or the trigger can be initiated by the patient. Then we have the cycle variable that cause the end of the inspiration, so the switching between inspiration and expiration. Then we have the basal variable that determines what's happened during inspiration. It can be zero pressure or a given end respiratory pressure. Then we can have also a limit variable that's less important, but limits the magnitude of any parameters. For example, the maximal pressure during volume control, or the maximum, for example, time during pressure support ventilation. So as you well know, during volume control, we have a dependent variable that is volume and a dependent variable that is pressure. During pressure control, we have an independent variable that is pressure and a dependent variable that is flow and in an integral over the time, namely the volume. At the same time, we can define a spontaneous breath. This is the one in which inspiration is both triggered, that means started, and cited, stopped by the patient. Instead, with a breath that is either triggered or cited by the ventilator, this name is called mandatory breath. So we can define a spontaneous breath, CPAP, and in CPAP, the pressure is just applied by the respiratory muscle. We can call a spontaneous breath a pressure support breath, for example, but in this case, the pressure applied to the respiratory system is generated partially by a respiratory muscle and partially by the ventilator. Differently, during a mandatory breath, the pressure applied to the respiratory system is only generated by the ventilator. So now we are going to analyze the critical phasing in spontaneous pressure control flow cycle breath, the well-known pressure support breath. And we have three critical phases: the beginning, the pressurization, and the cycle. And in order to understand this, we have to explain what inspiration delay is. Inspiration delay is the sum of the trigger delay from the beginning of the simulated patient effort, it's not simulated for the patient effort, to the beginning of ventilator pressurization. It is, you can see this red line, and the sum of the pressurization delay for the maximal deflection made by the simulation of the patient to the starting of pressurization. So then we have to define the pressurization capacity, represented by the positive area of the first 300 milliseconds of simulated patient effort or not simulated patient effort. Why this is very important? Try to think a patient that is breathing at a respiratory rate of 30. That means that his or her inspiratory time lasts during inspiration 600 milliseconds. If you have a delay because of poor pressurization of 300 milliseconds, that you lose half of the pressurization during inspiration. So there is a reason, because in this paper published by Cumello many years ago, more than 20 years ago, they found that the lowest pressurization rate caused the lowest tidal volume, higher respiratory rates, and highest work on breathing, as shown on the first curves. They are shown in these pictures on the left side. So this is a very interesting slide. It's come from a paper published in the Blue Journal by Lofaso in 1996. Two ventilators. On the left side is a turbine-driven. On the other side is a high gases compressed ICU ventilators. So the same pressure applied to the respiratory system. We can see flow, tidal volume, pressure applied to the respiratory system, and esophageal pressure. As you can see, the pressure applied to the respiratory system is exactly the same. This 20 centimeters of water, the same on the left and the same on the right. But if you go to see the effort of the patient measured by the swing in esophageal pressure, the high compressor air ventilator performed much more better. Why? Because if you can see the dependent variable of the pressure, that is in this case is a square pressure, that is flow, the flow is much more sharper during the high compressor delivery ventilator compared to the turbine one. Okay, same pressure. But this was 1996. And time passed by. Interestingly, till demonstrated in 2009, 13 years later, that on average, turbine-based ventilator performed better than conventional ventilator, which showed no improvement compared to the bench comparison in 2000. So time passed by. So another important variable during a spontaneous pressure support breath is a cycling variable. As you well know, during pressure support, switching from inspiration and expiration depends on the drop in flow. That usually this threshold is 25% of the peak of the inspiratory flow. If you have 100 inspiratory flow, when the pressure drops to 25, the expiratory valve open. But 25% was the given expiratory threshold that could not be changed many years ago. Right now, the performance of the ventilator changed, and they allow to change the threshold, for example, to 5% to 70%. Why? Is this efficient? No, it's not efficient. Because to any threshold, 5, 25, 50, 70, for a given peak inspiratory flow, we have different inspiratory time. And this is really very important. And why it is so important? Because the data saw in this elegant paper published in the Blue Journal in 2005 demonstrated, especially for COPD patients, switching for an inspiratory threshold time, for example, 10% to 50 or 7% in an obstructing condition, reduce the inspiratory time, PPI, and waste effort. And on the contrary, in a restricted condition, is completely different, because to switch in the opposite direction, for example, to 70% to 5 to 10%. So different condition, different underlying disease, different setting of the inspiratory threshold time. So, go on, battery. Battery have a real importance in a home care ventilator. Usually home care ventilator have a long-lasting battery, 3 to 9 hours, usually with a short charging time. However, battery life may depend on the parameter set on the ventilator. And in addition, some home care ventilator have a plug-and-play system battery, providing energy up to 12 hours or more. And this can be very useful when patients are outside of their usual environment, or in case of long-lasting manpower energy failure. It is energy failure in some countries is a really important issue. And some other home care ventilators have also a 12-volt car plug for battery recharging. And this is also important issue when during long travel, especially in the United States. So what are the recommendations? Physician and the respiratory therapists must be completely aware of the differences in interval gas input and face variable performance when choosing home care ventilator. One thing is choose a home care for a patient is completely passive. For example, the patient affected by LS in advanced stage, so completely passive is very easy to be ventilated. Different when we are dealing with a pediatric patient or patients that are completely active. So another important issue on a low pressure oxygen inlet is used, as in the home care setting, oxygen tension is never constant, and depends on the parameter set of ventilator. For example, at a given time, you can read 30%, then the minute of ventilation change and oxygenation change as well. As I told you before, if you have a completely passive patient ventilated 500 milliliter per 12 respiratory rates, I mean, the oxygen tension remain always the same. But when the patient change his drive or her drive, and the medium ventilation or their ventilation change, oxygen change may change as well. So when choosing also a home care ventilation and additional oxygen consumption for a given minute of ventilation must be taken into account. And in some markets, oxygen may be a real cost issue. The charge life of the internal battery, as well the possibility of using a supplemental battery, must be taken into account for patients. We spend many hours at their home. Remember that our mission is to send patients at home, but also leaving this patient to go out from their environment. They have to leave. And this is also important in areas where main power is frequently interrupted and where electrical backup is inconsistent. Another important recommendation, I want to stress this point, that is really pain in the neck. And not among different ventilators, and sometimes inside the same ventilator, changing from one ventilator for another one. In bi-level ventilator, for example, you switch to one mode, then you switch to another one, and the setup governing the pressure to apply to the respiratory system when the independent variable is pressure, namely the pressure control modes, may differ between home care ventilation as well as within the same unit, depending on the user setup, relative or absolute. In this case, I put peak 5 and pressure support 20, and is a relative setup, and the pressure, total pressure is 25. If I switch to a bi-level condition, okay, we switch to from relative to absolute. That means that you apply 20 and 5, the real pressure above EPAP, PEEP, whatever you want to name this, the baseline variable is just 15. Please take care of this. So we go another important issue, type circuits, valves, and CO2 rebreathing. Well, we can have 3 types of circuits. The well-known double limbs in different configuration, and we will see in a few seconds. And we can have another non-vented circuit, so with a real valve, during this valve called mushroom valve, one limb, one mushroom valve, inspiratory is in direction, expiratory in direction. In terms of rebreathing, exactly the same. CO2 is completely eliminated by the valve. Then we have another circuit, the so-called vented circuits, almost the circuit for definition for non-invasive ventilation. There is no valve, just one lip, no valve, and we have just an isolation system that is embedded inside the interface or proximally to the airways into the inspiratory vented circuits. So we start to talk about single or double circuits without an intentionality, so non-vented configuration. So we can have a conventional double respiratory system. We can have a double respiratory system with a distal flow sensor that is able just to measure inspiratory and expiratory tidal volume. So can be used either as a simple monitor tool or to control some of the ventilatory function. Then we can have some kind of double hybrid ventilatory circuit. This is the case, for example, of LTV. It likes one non-vented circuit. It is a really double one, also because it is equipped for a flow sensor, so it's able to measure inspiratory and expiratory tidal volume. The only difference that the expiratory valve is not embedded inside the ventilator, but they apply to the distal part of the expiratory circuit. So this is a well-known LTV, and this with the expiratory valve. So it's not embedded inside, but the ventilator behaved exactly the same on the conventional double limb circuits. So then we move to the really single non-vented ventilatory circuit. They are maybe less, their use, at least in Europe, I don't know, in the United States, but its use is much more less than many years ago. And we'll show you why. So they can be equipped whether or not with a flow sensor. If they have no a pneumotachograph, a flow sensor, yes, they can measure inspiratory tidal volume. In this case, they can measure both inspiratory and expiratory tidal volume. So one important issue with non-vented respiratory circuit is the circuit compliance. The effective compliance of the respiratory circuit, is a combination of the tubing compliance and gas compressibility. Some care ventilators provide automatic compensation for circuit compliance and resistance after the calibration maneuver. Others have the option of choosing between an adult or pediatric circuit configuration. Others don't have an automatic compensation, but have a distal proximal flow transducer or sensor, whatever you want to call them. We limit completely the drawbacks of not having circuit compliant measurement, because flow is measured proximally to the airways, and this is the case, for example, of the LTV. But we have a pain in the neck. The pain in the neck is generated by valves, unfortunately. Valves are important. They govern inspiration and expiration. All the ventilator for ICU have valves, as the home care one, but they can generate trapped volume. I will show why. This is an very old paper published in 1998 by Lofaso. And they found that in a non-vented one-limb mushroom valve circuit, well, these circuits, this expiratory valve, this mushroom valve, increase the expiratory time constant, generating intrinsic PEEP, and have a clinical relevant impact on the respiratory effort on patients with a high ventilatory demand. You can tell me it was 1998. We didn't use a double respiratory circuit. We used one non-vented mushroom valve circuit. So time passed by. So what? So what? So what? I would not say so what, because Thiel did this interesting study in 2009 using a double circuit of, you can see, very common ventilator in ICU hours. Some of them are still in use. Well, when, for example, the PV840, when they simulated two conditions, 30 of respiratory rates and 60 of the respiratory. Well, in both the conditions, when the patient was breathing at a higher respiratory rate, 30 for adults, or simulating a pediatric condition, 60, they found that the amount of trapped volume was very high indeed. So the cometer, even sophisticated Bible of ICU ventilator, may generate trapped volume at a high respiratory rate. Another important issue is CO2 rebreathing and dead space. We have to understand one important issue. All that stay beyond the white connection, the white pieces, and patient airway is a dead space. Catheter mount, HME, track tubes, mask, helmet, whatever you put beyond the white piece is really dead space. This is important. Then we move to another issue. If we know that some ventilator is not provided with vented circuits. This, for example, is the case of LTV, but it's not a criticism, because I have to speak about the world of care ventilator. Some of them is provided with so-called intentional leaks or vent circuit. So we do not have a through expiratory valve. So we have just a single limb. We have a vented system embedded in the mask, in the interfaces, or we can have a whisper vented system proximally to the airways. Well, we had a lot of discussion for many years about CO2 rebriefing in vented circuits. I can tell you that I did a lot of measurement by myself with the help of the companies. We did a lot of recent measurement so far, also with some very important company in the field. So we know that the given pressure, CO2 rebriefing depends on level of PEEP or EPAP level, and we will see an interesting study in a few seconds. Type of interface, dead space, flow through the vented system, place of the vented system outside or inside, for example, the interface, entitled CO2 level, respiratory rate, TI on T-tot. Well, but you have also to know that right now, the amount of flow that is vented throughout the vented system can reach about 50 liters per minute in some interfaces. Now, I want to show you an old study. This study was published in European Respiratory Journal many years ago, 2004. And before telling you the results of this study, I want to tell you that we have to define what the dead dynamic space is. And the dynamic space is the sum of the physiological dead space, namely the tidal volume, plus, for example, the space of the interface. So in this study, they went to compare the dead space of the mask, okay, the system without any flow inside. Then they applied IPAP pressure support 16, IPAP 16. They applied CPAP 4, and both the condition. Interestingly, they were able to demonstrate that PEEP, EPAP decrease decrease the dynamic dead space near to the physiological dead space in vented mask, while using just IPAP without EPAP was able to decrease dynamic dead space to a lesser extent. And this is the reason, because it is not only because of this reduction in dead space that the vented system have a given PEEP, but one of the reasons because vented system has a given level of EPAP is to clear CO2 inside the circuit. But it's not the only reason. We have also other reasons, and I will explain why in a while. There is another interesting study published by Schettino in 2003 that went to compare, for example, with different interfaces, two normal oral, nasal oral interface, one small, one just a more bigger than the first one, and the total full space mask. They went to analyze what was the driving pressure, the pressure applied to the respiratory system required to decrease entitled CO2 by 20%. For example, it was a bench study from 65 to 70. They found an interesting issue that depending on the space of the internal space of the mask, the amount of pressure was just a bit higher, switching from a small mask to a bigger mask. Maybe not so much, but 3-4 centimeters of water. It is a very important message, because we have to know when we switch from the small mask to the bigger one, we have to help our ventilator to clear the CO2 by using just a bit more pressure applied to respiratory system. Anyway, going back to the real clinics, there is a very well-known study powered by Lemise in the Critical Care 2013. In this study, his group used a turbine-driven ventilator in a DNI patients. And the aim of the study was to demonstrate that the earlier you switch from the conventional oral nasal to a total face mask, the less is the stand of skin breakdown. Anyway, interesting, we did arterial pH, and the PCO2 with a vented circuit, turbine-driven vented leak ventilator. Well, even they switched from one small to a bigger mask without changing the setting, the CO2 was strangely and less even after many hours using the total full face compared to the smaller oral one. So I want to tell you that in 2023, the likelihood of CO2 rebreathing a dynamic-based space may be decreased by ventilator setting as well as by mask-based system configuration. So, but not all is glittering, is gold. This kind of circuits, in case of overall leaks what mean? Intentional leaks plus non-intentional leaks. In case these overall leaks exceed the turbine compensation per leak of leaks, turbine compensation leaks can lose in performance. So in terms of pressurization, in terms of accuracy also of the tidal volume. So this is a drawback to keep in mind. But last about leaks, we have another important issue in the venting system, the so-called oxygen bleeding. The higher the leaks, the oxygen that is wasted through the venting system, and the more is the need of oxygen to feed the ventilator. So what are the recommendations? Respiratory circuit feature are mandatory. It may be possible to use different circuits configuration in the same ventilator according to the clinical choice, non-invasive ventilation, invasive ventilation, but we have to know how this is, what are the algorithm behind the circuit configuration. Physician and respiratory therapists must be aware of compressed volume and dead space or respiratory circuit, especially in pediatric patients. As I told you, if the ventilator is equipped with a distal flow sensor as an LTV, we can work out completely the problem of the compressed volume. So any connector placed between the wide pieces and patient airways in a double respiratory system or between the proximal through non-rebreathing valve or venting system in a single respiratory circuit may affect physiological dead space. So when using a venting configuration, many factors may affect the amount of rebreathing, as I told you, but I can tell you that in 2023, I mean, the problem is almost negligible. A higher level of intentional plus unintentional max leak may interfere with ventilator pressurization in FiO2. So this is a possible drawback in this ventilator. Then we go to another important issue is more volume measurement and leaks compensation. So I hope not to get you bored. So what VT is measured? Tidal volume can be measured by a flow sensor, by a flow transducer, by a pneumotachograph, or can be estimated in ventiscale. The important issue is to standardize the analysis of the tidal volume entering into a respiratory system. The tidal volume obtained by the pneumotach must be converted for ambient temperature pressure, ATPS, to the body temperature and pressure saturated gases. So we have to speak the same language, or ATPS or BTPS. Why? Why? Because even the most sophisticated flow sensor, how does a flow sensor work? Is a flow different transducer, so measure a difference in pressure on resistances, and so it measures flow. Flow over the time is volume. So even in more sophisticated ventilator, the tidal volume indicated by the ventilator can be lower than actually the delivered VT. And the difference can be reached up to 10%, even something more. So you set, for example, 100, but the patient gets more, just a bit more. Then, instead, in vented configuration, tidal volume is estimated, is not measured in very simple word, but very simple word, because the mechanisms behind this measurement are much more complicated. As I told you, the ventilator have always a given level of EPAP. It is mandatory to make an estimation of this tidal volume. Anyway, in simple word, is all the flow that is coming out from the vents, this flow, minus the flow that is coming out from the inspiratory leaks through the vented system is what the patient gets. And I tell you more, if you have non-intentional leaks, the ventilator is able to compute these additional non-intentional leaks, can subtract the flow that is coming out from the ventilator and try to give you a real estimation of the tidal volume. I tell you that there is some company in the United States that using tidal volume, estimation of tidal volume, and these companies are certificated by the FDA to estimate tidal volume for patients, pediatric patients weighing 3 kilos. So this interesting paper, if you want to read more, read this interesting paper by Luciano a few years ago. So what about leaks compensation? The problem with leak compensation comes out in urinary invasive ventilation or in a pediatric patient during ventilation through an uncatheterized tube. So is intentional versus non-intentional leak circuit configuration able to do better in terms of patient ventilator synchrony and non-intentional leak compensation? Well, go on. This is a very old study published by Schmidt and Schneerson many years ago. They went just to demonstrate that volume control, pressure control did better than pressure control in terms of leaks compensation. Everybody knows right now that pressure control is able to compensate better. But interestingly, they used two pressure control ventilators. One was in intentional leaks, the other one was non-intentional. Interestingly, the old BiPAP ventilator was able to do better than the non-vented configuration. This was many, many years ago. So why? Why? Because in non-vented circuit, non-intentional leaks is computed at the beginning of inspiration, is not considered as a bystander. So extra leaks is considered as a part of the delivered VT. In other words, is a flow sensor is measuring the non-intentional leaks, the tidal volume, the tidal inspiratory tidal volume is higher because it takes into account of the leaks. And unfortunately, the higher the leaks, the higher the VTI, but unfortunately, the lower is expiratory tidal volume. During vented ventilation, intentional leaks plus non-intentional leaks at tidal volume are computed throughout the respiratory cycle. And non-intentional leaks is not considered in the part of the liver VT. So estimated tidal volume is computed using algorithms that may vary among companies, and they should remain constant in presence of linear non-intentional leaks. Linear volt is the leaks through the vented configuration. These leaks become non-linear, the tidal volume can become non-accurate. So this is what's happened for example, in a double respiratory circuit, in a non-vented configuration. This is the simulation. We have a simulation of leaks. Tidal volume increases, inspiratory, but expiratory tidal volume, unfortunately, decreases. So when a leak is produced, we have a decrease in expiratory tidal volume. So is there any difference between vented and non-vented configuration in presence of non-intentional leaks in pressure control flow cycle breath? So many years ago, we published this study. It was a cornerstone study because at that time, we didn't have any leaks compensation in our ventilator. And this on the left side, we have a pressure control breath. Okay, that means a time cycle breath. And on the left side, we have a flow cycle breath. As you can see, a big mess, leak, missed effort, fail to cycle off. We were lucky because time passed by. Now on the ICU ventilator and in most of home care ventilators, we have compensation for leaks during double leaks or non-vented configuration. But it was clearly demonstrated that when the Miyoshi plotted the sophisticated 840 ventilator or the old 72000 Puritan bedded ventilator compared to a very simple BiPAP, we were at the time without NIV leak compensation. Well, the trigger delay was much more better during B-level vented configuration compared to doubling. I repeat, time passed by, but it's not all. But in 2010, Cardot and Laurent Brochard did a very interesting study. They went to compare ICU double circuits with NIV software and without NIV software, compare to a vented configuration, an old respiratory inhibition, vented configuration, no valve. What they found, the asynchrony index was 0. So the patient ventilator synchrony was much more better without valve than with valve. Okay, and this was the conclusion of the paper. So another important issue, even in United States, the dual mode are so common, but we know that we have some company, they are provided the called dual mode or pressure control, volume regulated. Is there any difference between venting and non-venting configuration? It is an interesting study was carried out by our group, also by Brigitte Valou and Sonia Kirani in 2013, the same years. Well, you can see the slide you have seen before. We have the same simulation. You produce a leaks vented configuration, or the 3 ventilators are configured in vented configuration or non-vented configuration. You can see that during the leaks in vented configuration, we have almost constant maintenance of the preset tidal volume, okay? While during non-vented configuration, unfortunately, the pressure went down and the expiratory tidal volume went down, while inspiratory tidal volume went rise up. And you can see on the right slide, this is the behavior of non-vented. The pressure drops, okay, in front of leaks, because the algorithm is linked to inspiratory tidal volume, so inspiratory tidal volume increased. So the pressure decreased because they interpret the inspiratory tidal volume as a tidal volume, as the tidal volume was caught by the patient, but it's not the real life. In the vented one with different algorithm, the ventilator was able to maintain the tidal volume. And I want to see the real life. This is a patient at home during telemedicine. The patient was tracked, it was a pediatric patient, and you can see an increase in minute ventilation, okay, during uncovered tracheostomy ventilators, increase in tidal volume, decrease in expiratory time in minute ventilation, and you can see some REM correlated desaturation. Well, this was ventilated in non-vented configuration. We switched the patient exactly with the same support from non-vented to vented the night after. So the leaks were completely compensation during the vented one. I know that, for example, we had I'm coming from the ERS Congress, and we discussed this issue recently about using a vented configuration even in tracheal patient. In Italy, I tell you the truth, few physicians use a vented configuration in tracheal patient. I know the UK, for example, they use vented configuration much more in tracheal patient than in Italy, for example. So some company tried to be very tricky and say, why I'm much more smarter than company measuring expiratory tidal volume. I would like to use expiratory tidal volume. And they did a big mistake. I tell you why. Because if you want, if you link the PRVC to the measurement of tidal volume, what's happening in case of leak? The higher the expiratory leaks, the higher the flow, that the increase to maintain a given level of PEEP, because the first mechanism the ventilator acts is to maintain level of PEEP, so increase the flow. And increasing the flow results in much more tidal volume going out from native patient airway. And this would result in an underestimation of expiratory VT. And this was clearly demonstrated by Brigitte Farou that found, I covered this because I don't want to know which kind of ventilator was, but measuring the expiratory VT, we have a bigger overshooting from 600 milliliter to 1000 milliliter. So expiratory measurement of expiratory VT is no longer used in dual mode. So recommendation, vented circuit better compensate for non-intentional leaks, especially I love vented in non-invasive. VT estimation, but it's my opinion, vented estimation in vented configuration is pretty good, and bias are comparable to non-vented configuration in presence of linear leaks. Dual mode, expression control, volume guarantee mode in vented configuration can maintain set VT much more better than double limb circuits. And patient ventilatory signal can be improved, especially during non-invasive ventilation. I just tell you the state of the art. What about user interface, alarm, and portability? And then I'm going to conclude. Sorry to bore you. So user interface, recommendation. User interface may vary significantly among on-curve ventilators. Unfortunately, there is no consistency among manufacturers in terms of labeling ventilatory function. And there is a pity, really pity, particularly in ventilatory mode, wipe up, pressure support, pressure control, volume guarantee, assist pressure control with volume, a pain, a big mess. The larger number of ventilator modes can result in systems that are poorly designed, non-intuitive, and almost impossible to remember, with a subsequent need for operator to browse, to refer to instruction manuals in order to interpret poorly labeled control or to navigate multiple levels of software. As a consequence, the physician and respiratory therapist must be aware that will be often a learning curve for any home care ventilator. They often not so intuitive. Last but not least, another practical consideration is whether the monitor displaying the setting curve alarm is easy readable. This is an important issue too. Going on. So another important difference is to understand well what a life support, a life sustaining ventilator is. Not all ventilator is life support, and not all ventilator are life sustaining. And in order to understand the difference of life sustaining, life support, we have to understand the type of circuits, the ventilatory modes, okay? Volume control is life sustaining mode in a life support system, but we have also to have a ventilator equipped with full range of alarm, a capability of accessories, included battery, included a plug system to have more than 20 the 12-hour battery supply in case of power supply. Sorry, power loss of power of energy. The ventilator safety system avoid any damage to the patient due ventilator malfunction. In case of electrical failure, there is a room air inlet that will the patient breathe through a simultaneous opening of an inspiratory-expiratory valve. Unfortunately, this is true for still active patients, but this may be of little help or no help in patients that are completely passive. Another safety system is the presence of a pressure valve, but you know this overpressure valve sometimes is calibrated to 100 centimeters of water. This is that does not limit the risk of barotrauma. Safety system also include the use of microprocessor control function, be automatic responsive for events such as retracted ventilation in case of apnea, for example, backup ventilation. Then we have important alarm. We have, as I told you before, to pay a lot of attention in order to understand in life support a ventilator if you have enough alarm to consider this ventilator life support. So all ventilator can be considered life support device only if they respond to ventilator malfunction with proper alarm, no doubts. When you use a ventilator with intentional leak circuit, there is a risk of rebreathing when the ventilator idles, with the patient wearing an oronasal or total face mask covering eyes, nose, and mouth, only using a tracheostomy tube. Although it's not considered a home care ventilator safety system, an anti-suffocation valve embedded in the interface on invented respiratory system is mandatory, while an alarm on the breathing system is strongly advised in vented configuration. Portability is an important issue, very important issue, especially in pediatric patients, to allow them to move outside home using the ventilator in a carry bag attached to the wheelchair or having parents sling the ventilator over their shoulder. So I am at the end of the story, almost in time. So my conclusion, the home care ventilator hardware and software made a significant improvement over the years. There is no doubt. However, a careful evaluation of this feature is important before deciding which one for who, taking into account life support versus life sustaining configuration. The point of view of the patient in terms of assessment of his or her perception to the treatment is also clinically relevant because better patient well-being is related to a better treatment compliance, which is a critical issue in on-home ventilation, especially in those undergoing non-invasive ventilation. Since in many cases the primary objective of non-invasive ventilation are to alleviate dyspnea and improve comfort, is not seem reasonable to exclude the patient view on the treatment. I think it's very important, also in pediatric population. And portability is also an important issue, especially in pediatric patients. Thank you very much for your attention and scoring to God with you. Thank you very much.
Thank you very much, Professor Gregoretti, for your presentation. That was great. We do have some opportunity for a Q&A, so if there are any questions from the attendees, please feel free to write them in the Q&A. I can start the question time off with one question. It's actually a two-parted question. So the first part is, out of 10, with 1 being the least important and 10 being the most important, how important is portability for a home care ventilator?
I would say 10.
10.
Chloe, it depends also from a patient. I have no doubts. It's our mission is to take the ventilator, take the patient from hospital to home. We have to allow the patient to go out from the environment, okay, as often as possible. So portability, in my mind, counts 10, no doubts.
Great. And same question, but out of 10, with 1 being the least important and 10 being the most important, how important is the battery life?
Again, in my mind, you have to choose a ventilator beyond portability, beyond the performance. I mean, battery is really important. You know, you have to understand that we have to reason not only. I mean, I guess I want to change my reply. We have to reason. Our patient can live in New York City or in San Francisco, but can also live in Utah, or in some remote place, and they need power. Power means life. Is really important.
Great, thank you. We have a question that's come through in the Q&A. So, for patients with ALS, is a turbine ventilator more appropriate?
Yeah, okay. I tell you the truth. As far as I know, right now we have just turbine-driven ventilator, because until a few years ago we had a very famous ventilator. It was name called Newport. It was a micro piston driven ventilator. But as far as I know, all ventilators right now are turbine driven. I can tell you, but very, very sincerely, the turbine driven ventilator are even in ICU right now. So turbine driven means 100% safety. So you can absolutely ventilate your ALS patient with a turbine driven ventilator without any doubts.
Okay, that's great. I think that's all the questions that have come through, and we're at the top of the hour. So I just want to say a sincere thank you to Professor Gregoretti for your very detailed presentation. And thank you so much to all of our attendees who have joined us today. And I hope you have a great rest of your day.
Thank you very much, Chloe. Thank you very much for everybody for attending this session. Thank you. Good night.
Thank you.
Good day, United States. Bye-bye, Chloe.